Welcome back, everybody. We anticipated doing these videos, Gary and I, about every 2 weeks, but things happen quickly, don't they? And it's kind of deja vu from maybe a year ago. So we're back. It's August 5. Hope you're having a good day. I'm here with Gary again, and let's just dive in, Gary. There is a lot of news certainly out there. Can you tell us kind of the overview of what's happening in terms of cases around the world and here?
Yeah, so it is a good time to talk about the Delta strain again, because there's been a lot of movement and we've actually have some new understandings about it. And I get a lot of questions about this right now. It's clearly in the news a lot. I'm going to show you a couple epidemiology slides. Now, I hope you guys like these slides. I mean, we use these to be kind of instructional. I really like looking at the epi curves. So they kind of tell me where things are headed and how things are going. The first epi slide is kind of what's happening in the US. These are newly confirmed cases in the US. The blue line there is the average in the US, but it also highlights some of the states that are doing really well. And what we see, Gary, is that we see that states that don't have well-vaccinated populations, low vaccination rates, have higher cases. Yeah. And that's why we're still seeing this Delta variant surge be a surge of unvaccinated people. So 3 big states here. I'm going to pick on Florida, Missouri, and Texas. You could also put Georgia, and you could put Louisiana, you could put Colorado, Utah, Idaho. In the mountain states and in the southeast, they have low vaccination rates. And so you're seeing a lot of higher spikes than the normal in the US. The blue line there at the bottom is the US one, and that's kind of where California sits. Okay. So let me show you the next slide. The next slide is the PAM, I'm sorry. The next slide is the Sutter footprint. And I actually highlighted here the Delta surge to the right. What I want you to notice is that in the Delta surge to the right, where we are right now, the Delta surge is already a little higher than the very first surge we had last year. So the second wave we had was a hard wave, but you can see that this the Delta surge now is higher than last year's first wave. That being said, the Delta surge is not over. We're not done yet. And the question I'm getting is, how long is this going to last? And the next slide really talks about that. This is a slide that shows new cases in the US compared to the United Kingdom. And so the UK, the first person to see the Delta variant was India. And so India had a very long, protracted surge because they had very low vaccination rates. And then it went to the rest of Europe, and the UK kind of started to lock things down again. The UK is already on the downside of the surge. So I don't think the surge is going to last very long. We haven't peaked yet, but I hope we'll peak soon. And then once we get down that peak, it should go down. The only confounder there is when schools go back. And I just don't know if that's going to be a variable that prolongs it a little bit, but I still think the Delta variant is going to go down. Now, science is really key. We try to be evidence-based. And just so you know, do we know exactly why a variant comes and goes? We actually don't. Virologists are kind of struggling with that, and epidemiologists are wondering, what's really, there's so many factors on when a variant goes up and goes down, but clearly crowding is a big one.
It's true, all the historical charts you see, you don't see big plateaus, you see peaks.
Right, you see peaks.
As is evidenced by our history.
And we keep seeing peaks, and usually most of the peaks are a different variant or a combination of variants. Yeah. Now, the last slide I kind of made out to kind of summarize what I think about this new Delta strain. So, and there's a number of things I want to point out here. I'm going to spend a little bit of time on this slide. The first one is the R0 number, the basic reproductive number. So if you have a basic reproductive number, like for example, measles is 18, every case of measles in a vulnerable population will have 18 secondary cases. So measles has the highest R0 number of anything. The early strain called the D614G strain, that had an R0 number of 2.5. So one case could result in 2.5 cases. And then the alpha strain in the UK, that was really much more contagious. It had an R0 number of 4 to 5. So it's twice more contagious. Go to the right, and the right is kind of what we learned about the Delta. The Delta variant has an R0 number of almost 7. So it's probably almost 3 times as contagious as the original COVID-9 or SARS-CoV-2 virus that was circulating. Now, if you look at the incubation period of the original viruses, their incubation period is about 5.5 days. But now with the Delta variant, its incubation period is shortened down to 4 days. Because of the little molecular mutations that happen in the glycoprotein, allows it to attach, fuse, and replicate faster. So it's got a shorter incubation period. The next line is, what about vaccination to get to herd immunity? We thought that with the early strains, it would take about 70% vaccination and or natural infection to get to herd immunity. When the R0 number goes up, when the virus becomes more contagious, you require more vaccine for herd immunity. So now we think that herd immunity is going to be probably about 85%. Early on with the older variants, severe disease was manifest in the elderly and with people with comorbidities, obesity, diabetes, high blood pressure. But with the Delta strain, we're actually seeing severe disease in a younger population with or without comorbidities. Now, there's two reasons for that. One, I think it is a little bit more virulent. But two, the elderly are already vaccinated.
Right.
Vaccine works so well, the unvaccinated cohort is really in the 20 to 50-year range.
What are you seeing in the hospital?
I'm seeing exactly that. I'm seeing that people with 20 to 60 years old, but 99% unvaccinated are getting sick. We're not seeing elderly patients come in. I'm not seeing the elderly who got vaccine with a breakthrough that are now hospitalized. We're just not seeing that.
Okay.
A couple things. VE, and this stands for vaccine efficacy. So in the mRNA vaccines, Pfizer and Moderna, the vaccine efficacy early on was about 94, 95% against infection and symptomatic disease. And with the Delta strain, it's about 88%. So it drops from 95 to 88% for infection or mild symptoms. But for severe disease, the vaccine efficacy was at 95%, it's at 96% still. So the vaccine efficacy of the mRNA vaccines to the new Delta strain is exactly where it was with the previous ones. That's why we keep saying that the mRNA vaccines are holding up really well. They're preventing people from being hospitalized. They're preventing from people from getting to the ICU and dying. And so what we're seeing is a lot more mild illness with the Delta strains where people have a common cold or maybe even something that's so mild that they think it's allergies, for example.
Okay. And then this is all evidence, data that we have collected over millions of patients, I presume.
This data comes from a CDC a CDC presentation with internal and published data. Some of this data comes from the New England Journal of Medicine that was presented last Saturday. So these are new insights, new breaking insights.
Okay.
The last two I just want to mention, one is that vaccine breakthrough is rare in the previous one. Now vaccine breakthrough is uncommon. And that's because that vaccine efficacy dropped to 88%. But however, vaccine breakthrough rarely transmitted virus with the original strains. We know something new now from an outbreak in Massachusetts. The CDC was looking at this outbreak and it was published in the New England Journal. We realized that if you have a vaccine breakthrough, which is not very common, there's so much virus there that you're still going to transmit. You could potentially transmit if you're not careful. So people who have vaccine breakthrough may be just as likely to transmit virus as people who are unvaccinated but symptomatic.
Okay.
So a lot of information on this slide, good stuff for everyone. I boiled it down to one good summary point, and that is this. With the Delta strain, there's more viral burden sooner in your snot. So what that means is this has not become airborne. It's become more dangerous and more contagious because there's a lot more virus that replicates much earlier in the nasal mucosa and in respiratory droplets.
Okay.
It doesn't mean that this is now in the chickenpox, in the measles category, in the tuberculosis category. It's still predominantly a droplet viral illness.
So the process of transmission has not changed. The quantification of the viral counts is higher.
Right. So what the CDC says, knowing that vaccinated people can transmit virus if they become symptomatic with a breakthrough infection, that's why the CDC said everyone needs to wear a mask, vaccinated or not. And if you're symptomatic, even mildly symptomatic, you should be tested.
Okay.
We still need to wash our hands. We still need to social distance in public areas. Be careful of indoor gathering. Remember we talked about the bubble?
Yeah.
Be careful of widening your bubble because you don't know if someone's vaccinated or not.
Okay.
But it doesn't mean we need to put a HEPA filter in every room. It doesn't mean we're going to go to room turnovers of an hour. We're not at that point yet with this virus.
So to summarize all that, it sounds like despite the snot, we're still very reassured by the efficacy of our vaccines. That's still the major gun that we have in our pocket is the vaccination.
Yeah, vaccination is really how we're going to get out of this pandemic. Unless a new variant comes up, which we don't see yet, that could blow vaccine out of the water. Other vaccines in the world are not holding up very well. The Moderna and the Pfizer have been game changers in the US.
Okay. Now I'm going to switch to what we're doing here locally. We have standard protocols of how we're seeing these patients, because as you all know, we're all taking care of our patients en masse now. We haven't sequestered care back to the respiratory care clinic, which we closed down back when things were pretty quiescent. And so I just want to review that and just to want you to know that leadership spends an inordinate amount of time evaluating this at our level and every level above, in which Gary's very involved, around the safety of our patients and the safety of our providers. And so let's just talk about our standard work now. How are we protecting our patients? You know, the first thing we're doing is we have screening signs out front, and they're screened on the phone. People are told to stay in their cars. They're checked in their cars. They're then escorted into the building, directly into their exam room. Many of the offices, when possible, are using a back door, so are sequestering them pretty effectively in that.
And Gary, is that if people are symptomatic?
This is people are symptomatic, yes.
Yeah.
It really is symptomatic.
Okay, so symptomatic people still are in the cars.
Mm-hmm.
Symptomatic people are being escorted in.
Mm-hmm.
Okay, and that's
Bypassing the waiting room.
Right, and that separates
Yeah.
asymptomatic.
The second way we're trying to keep our patients safe is by cleaning the rooms very effectively after we see them. And along those lines, I'm hearing some people question our current standard of care about turnover, and that is we wipe the rooms down well and we can utilize those rooms again. Has anything changed in that regard?
No, I think the Delta variant is more like RSV and influenza than it is like chickenpox. And so RSV, big droplets, lands on the table, you want to clean that snot. So I think wiping the rooms down is really key. Mm-hmm. If you do an aerosol generating procedure, like you put someone on a nebulizer because their asthma is flaring with an illness, then that aerosol generating procedure will have to close the room down. Mm-hmm. But other than that, the other one is, and we're talking about this, is what if an infant comes in and the infant's crying and you can't cover the infant, it won't wear a mask and you don't want to cover it. That is like an aerosol generating procedure. So we're going to figure out what are our room turnovers and do we need to enhance anything in those two settings. Other than that, it's business as usual.
Okay. And that last thing about pediatrics, we actually spent time talking about this morning in our leadership meeting. We're investigating different avenues to address that, so more to come on that. Right. Then let's talk about what are we doing to protect our providers and our staff. And I think that comes in a couple ways. None of this is new news. It's our PPE, which we've been using for well over a year, which has been deemed to be very effective, as evidenced by the lack of transmission in the hospital, in our clinics, and you're all very aware in doing that. And then the second thing is the efficacy of the vaccine. Some of the things you just talked about. I think you have some more newer evidence about the vaccine.
Yeah, let's talk about the vaccine, because this is really good. This is published from the New England Journal of Medicine, and the CDC actually put it into their presentation. This slide is efficacy of the vaccines with the new Delta strain. And so against symptomatic disease, 94% effectiveness for the alphas and 88% for the Delta. And peer reviewed in the New England Journal, against hospitalization, the vaccine efficacy does not drop at all. So this is really important, and the CDC is leaning on this information to make their recommendations about masks, about PPE, and so we're not moving to PAPRs. You know, we know that N95 and the face shield is really going to be very important with the Delta strain.
Okay. And really, that's the game changer for us, isn't it? That's what allows us to be safe. In fact, I just saw the statistic that the state of Virginia said in the last 6 months, 99% of their hospitalization, 99% of their deaths have been in unvaccinated people.
Yeah, I think last time we made the statement that this Delta surge is an unvaccinated surge, and that's still true today. You know, and so the chance of a breakthrough infection, slightly higher. The chance of being seriously ill, almost zero.
Good.
You know.
So those are the issues that we address when we have set up this system for all of us to see patients in unsequestered care. And I think it's really important that we all own and understand this safety, because that's critical. That is what allows us as leaders to ask all of you to fulfill your role as being part of the SMUGR team. We have 120,000 patients who come to us for care, and they're asking for a lot of care right now. Demand for care is high, and so we need each and every member of our team to play the role and assess these patients. And now you know that you can do this safely without fear for your health or your family's health. So thank you for being part of that. I also want to talk about exposures. So, you know, exposures will occur. We know that's the case, not 100% effective. Gary, can you remind us what is the definition of a high-risk exposure?
Yeah, so high-risk exposure with any of the strains, and it hasn't changed yet with the Delta strain, is you are within 6 feet for more than 15 minutes with inadequate or no PPE.
Okay.
So that's a high-risk exposure to a patient who's symptomatic, as suspected of COVID or confirmed of COVID.
Okay. So first of all, that should rarely happen. right? Because we are donning PPE in anybody who's symptomatic.
Right.
So that shouldn't be an issue. But I do have a slide to give you instruction on what to do in situations where you feel you might need to be tested. So first thing is if you have an asymptomatic exposure, so you are asymptomatic, but you have undergone an exposure to the order of what Gary just talked about, we do want you to be tested. We recommend you be tested the day of the exposure as soon as possible thereafter, and repeat testing on day 5. During that time, you can continue to work. You're asymptomatic, and we've demonstrated with the test you do not have COVID. If, on the other hand, you are a person who's developed symptoms, and this doesn't necessarily mean after an exposure, this could just be you have symptoms, and quite honestly, most of our exposures probably occur out in the community. If you have symptoms, we do want you to be tested on day 0. And Gary, you made a good point this morning. If that test is negative, you do not need to be tested again.
Correct. Yeah, if you have mild symptoms of anything and you're not sure, is this allergic rhinitis? Mm-hmm. Is this from smoke? Is this my asthma? Is this a cold from my kid? Or could this be COVID? And you get tested and you're symptomatic, that test is negative, you're good to go. You don't need a second test, and what you have right now is not COVID. Okay. The negative predictive value of our testing is extraordinary.
So in both of these situations, you may continue to work. In the latter one, if you have symptoms, obviously we don't want people working if you're febrile, or if you feel incapable of working, that's a different story regardless of what illness you have.
So that's a good point, Gary. So let's say I come to work with some mild symptoms and I get tested. If I get tested and my test is negative, I can come to work.
Yeah.
However, we've always said, if you have a fever, don't come to work. So that predates the pandemic. We've always said that. If you're febrile, you can't be at work. That's an infection prevention policy. So the only time you can't come to work with symptoms is if you have a fever, despite your COVID test.
Okay.
Yeah.
Okay. And at the bottom of this chart, I've posted how you can get tested. We used to have pathways you have to go through. Now we don't do that. This is the back line for same-day care. So if you are a provider who needs to be tested, you simply call the back line of same-day care. They have the protocols there and should be able to test you and get you back to work or make you feel comfortable about what you're going through.
Wait a minute. I thought that was going to be Steve Mitnick's cell phone number. No?
It might be. Gary, a few other things topical. Is there anything new on the approval of the vaccines?
Yeah, so the FDA is about to approve the Pfizer vaccine. So it's about to come out of emergency use to be just FDA approved, just like we have for flu vaccine and tetanus vaccine. So we're expecting that within the next month. And then the pediatric information, the pediatric data is being submitted to the FDA, both by Pfizer as well as by Moderna. Pfizer's a little bit ahead of the curve on the pediatric data. And we hope to have the FDA give a ruling, maybe in October. They're going to look at the data in September, and from October to November, depends on their time schedule, we hope to have a pediatric mRNA vaccine approved in the United States.
And do you happen to know, is that down to age 2, down to age 5, or where are they?
Yeah, exactly. We don't know. It depends on how much data is collected. Optimally, we want it down to 2. Yeah. But if the data is being presented quickly and we don't have all the robust information, it might be only presented down to 5. It's not that it's any less efficacious, 2 to 5. It's just how many of those kids have you included in the study, and what is your p-value?
You need to feel comfortable. Okay. Well, let me just finish with telling you what's on the horizon. You may have heard that the state of California put out a public health mandate last week, which states that all providers in healthcare, all employees in healthcare, so that's all of us, are required to either be vaccinated or to have testing once a week. And that's going to take effect on August 23rd. So that applies to all of us, either be vaccinated or to undergo testing on a weekly basis. And then you should have received an email yesterday from Sutter Health, which has gone one step farther, and that is by September 30th, the expectation is that every employee and every smuggler provider will be vaccinated, with the rare exceptions that have to be documented by a religious or health exception. So that's what's coming, and I think that's going to continue to make us feel good about the way we're providing care and make our patients feel better about where they're seeking out care.
Yeah.
So thank you for your time. I know there's a lot changing. I hope you find this is useful for you to spend a few minutes with us. And Gary, I do want to come out. I don't say this enough. Thank you for your time. Gary's working hard. Gary said he has 11 patients in the intensive care unit right now. He's at the hospital all night, many nights, and every evening. So thank you for spending your time with us and imparting your knowledge. I know you get a million questions and phone calls every day.
Yeah, the good news is it's not going to last forever.
Yeah.
We're going to get through it. The pandemic will end. You know, it feels like a marathon run.
Yeah.
But I'm just glad to do it in this group. I mean, it's really great to be a part of the group, and I really appreciate each and every one of you. So thanks for everything.
We're glad you're here. All right, thank you. Have a good rest of the day.